and very nice to be here. And thanks, Rachel, and all the organizers for making this happen. It's an excellent conference and a very good opportunity to meet and collaborate and discuss all these important topics. So anyway, I'm Patrik. I'm the Chief Medical Information Officer at Karolinska University Hospital. And I'm going to start talking a little bit about our journey that really started in 2019, 2020, and it's actually accelerating right now. So it's a very exciting time. And this is where I usually always start. It's very simple, but people forget these simple things, so I think they're worth mentioning every day. So clinicians, patients, and researchers make decisions based on data. If we have bad data, we will make bad decisions. If we have good data, at least we have the possibility of making good decisions. This is a foundation, but we tend to lose the simple things when we get into the weeds of these discussions. And this is healthcare in one slide. It's a little bit busy, but I challenge all your clinicians to tell me if something is missing here, but I don't think that anything is missing, apart from one thing, patient engagement. So this is a healthcare perspective. Anyway, so it always starts with patient needs healthcare in some shape or form. They come to us, virtually or physically. We collect data and we document our findings. We do a lot of diagnostic investigations. At some point, we have enough data to make clinical decisions. So clinicians need available, correct, and complete data. If we need to have a computerized decision support system, the data also has to be machine readable. Then we apply medical knowledge, make a decision, make a care plan, and do everything that needs to be done. And at the end of the day, we need data to adjust the treatment for our individual patients. We have to update the best practices like clinical guidelines and so on. We have to improve efficiency of healthcare and enable research. And the fuel that drives this cycle around is the data. Without the data, you can't even start the car. So you can forget about all the fancy stuff if you don't have the data. We can just go home. So it starts and ends with the data. So are we solving the right problem? I think they should be more concerned with the train passengers there. What do you think? This is not an AI-generated image actually, so I'm wondering how did this happen for real? It's very strange. But I think it's a very good image illustrating what we actually are doing many times. We're focusing on all the cool stuff there, Internet of Things, new EHRs, wearables, mobile, cloud, telehealth, and now the latest thing, AI. All things, those are great. But if you don't have the data, you can just go home. So I said, I would much rather have only the data and actually get rid of much of the stuff over there. And this is another way to now moving towards why openEHR. Traditionally in health IT, we have had two choices, best of suite, by Epic, by Cerner, or something like that, or best of breed, the traditional way that let every specialty just buy their own system, let the radiologists buy their RIS packs, let GPs buy their system, and let everything do what they want. And on this side of the thing is that you can get tailor-made applications. You can have rapid development, at least at the beginning, and clinicians can control data, logic, and workflow. But on the other hand, why would you want to have that? Well, you can have, theoretically at least, an integrated solution. We have the right data available to the right person in the right format through the right channel at the right time. And so we have been this tug of war. Should we buy this Epic, or should we have like many small fragmented systems? Well, why not have both? So we can use openEHR can be the platform that really create this integrated IT environment, but you can still allow the clinicians to adapt and develop the applications they need for their particular use cases. So I think you can really cut the rope there in between, because you don't have to have this tug of war anymore. And this is healthcare IT in one slide, admittedly extremely simplified. I'll just talk you through it. In the middle, we have the electronic health record. In most places, even in the places having Epic, so they have specialist systems. For example, it's quite common that you have a specialist system for intensive care. Or you can also have specialist systems. You can have systems for patient monitoring. You have radiology information systems, you have PACS systems, you have laboratory information system and automation systems. And most healthcare providers also have an analytical data layer. So at Karolinska, we really go all in for a standardized approach where openEHR is the centerpiece for clinical data. But we also take a standards-based approach for the other areas of healthcare, like IEEE for patient monitoring, DICOM for imaging, OMOP data model for research, and so on and so forth. So it's not a one-size-fits-all. But the common thread here is we want to standardize the data and make sure that the data is of the best possible quality for all users. Now, on to something more practical. This was just my introduction. So what have you actually been doing at Karolinska? I'll just give you small examples to make it concrete, so feel free afterwards to ask me anything you want, because I could go on for 10 more slides, but we don't have the time. So I just picked a few. This is for oncology. A normal treatment for a cancer patient is quite long. You have a chemotherapy course that can go on for about 6 months. And then the patient comes back for treatments, for example, every second or every third week. And before every new treatment assessment, we want the patient to report how they're feeling, the symptoms, the pains, tiredness, and nausea, and so on. So what we did was we created an openEHR-based form that we're fill in and answer questions, how they're feeling. And we pushed that out into an existing mobile application that all citizens in Region Stockholm have in their phone. So we didn't create a new one. We just pushed out an openEHR-based form into the app. And so they can report how they're feeling. And they have the oncology management system, where they have all their chemotherapy treatment planning, and have a laboratory information system where you can, for example, check the blood leukocytes and so on. So, and then the nurses have an application here. So they can say, oh, okay, how are the patient feeling? Are the lab looking good? And how have you ordered the chemotherapeutic drugs or not? And they say, are the patient ready to schedule the appointment? So we can order the medication. This seems like an extremely simple thing, but it's very useful, because if the patient arrives and have ordered the chemotherapeutic drugs and they can't receive the treatment, you have to throw away quite expensive chemotherapy drugs, and the patient has to come in for nothing. So it's a very useful application. Another example, we are using openEHR for pathology reporting, and we have a collaboration with the Sectra, I think the RIS-PACS vendor that exists even in England, I think. So what we did then, because now the pathologists are working digitally, so they don't look in the microscope anymore. So, but the Sectra solution have an own proprietary form builder where you can configure the form where the radiologist and the pathologist write the report. So why replace that? Let's just keep them use that. So what we did instead, we had a collaboration with Sectra. We said, we want the radiology report and pathology to end up in the openEHR CDR. So we actually gave them an openEHR template, and they semi-automatically was able to use that to build the form in their proprietary form building tool. So when the data was exported, it was natively in the openEHR format without mapping. So a very practical approach for us. Minimal disruption for the radiologist, and they didn't even notice that they went from a purely proprietary RIS-PACS solution onto an openEHR-based reporting. It would be almost unnoticed. And then, of course, the point here is that the openEHR data can now automatically be sent to the cancer registers, and it's automatically available in our trusted research environment for free. This is another example. A general example for patient-reported data. Once again, the mobile app over there is something that's all the citizens in Region Stockholm have had for, well, almost 15 years, so we didn't feel the need to replace it. So what we did instead was say, let's just build a the form using the openEHR tooling. The care team can do that by themselves. And then the form is pushed into the existing mobile app. So it's just integrated as a form within the existing app. So the video meetings thingy and the appointment booking chat and so on was already existing. We haven't added that. It was already there. We already added the forms to make assessment and be able to collect prems and proms. Then that ended up directly in our platform. Once again, a very seamless approach, very easy, not disruptive in any way. Another example, Karolinska focuses heavily on research. And now we have a lot of source systems to the left. We have patient-reported data, you have our main electronic health record, we have the PDMS for intensive care, and I can go on. We have more IT systems on the left side. So we're moving it into our platform. And yes, here it's some heavy lifting has to be done to map it over here. But what I want to point out, if you have done that heavy lifting, you have FAIR for free. Findable and accessible, interoperable, and reusable data, which is sort of a standard within the clinical research community. And it's it's quite easy to, if you want to have it in OMAP format, to go from openEHR to OMAP. It's a much more heavy work to go from the source system over to the left to OMAP. This is an example of how we use openEHR for what EHDS calls secondary use of health data, quality reporting and research. Did I have any more examples? Yes, I had one more. We have a very interesting collaboration with in Sweden we have, I think it's 107 national quality registers. And this is a collaboration. We have the National Cancer Registry platform. I don't remember exactly how many cancer registries we have, but they're about 30, 33 perhaps. And so what we're doing now, the left side is the work in Region Stockholm that we have talked about up until now. But now the registry platform are also saying, well, why don't we do the same thing on our end? So let's put an openEHR platform here, and then they can pick the data needed for every different registry like this. And well, all of a sudden, this is a non-issue. This is for free. Because we are already doing this on the left side here. And since this register platform, they had many registers, they already had, not openEHR based, but they had something that tried to be what this is now. Because they had to receive the data from the healthcare providers in one place and sort it out into the different registers. So for them, it was not a big leap to why not choose openEHR? Because, and just as a small side note, we started this a couple of years ago, and at that point, the register had no experience with health data standards at all, basically. They didn't know FHIR, and they didn't know openEHR or anything else. So we said, you might think that why not just use FHIR here for data sharing, but for us it was just an unnecessary mapping step. Why not just go directly? We're already using openEHR, and they have no know-how about FHIR, so you might as well start with openEHR, and then we get this for free. So it works very nicely. This is just a summary picture of what we mean by our Karolinska University Hospital Health Data Platform. And I want to emphasize that for us, it's just both primary use of health data to the left and secondary use of data to the right. And it's not only openEHR. For example, for monitoring data that are basic waveform data, we use a time series database. We have a multimedia archive for images. We have a genomic data repository. And we also have a more traditional enterprise data warehouse for production data. But everything is integrated, and it's sort of logically, it's one platform. And I think for us, it's extremely important to view it in this way. And so when we say openEHR platform, sometimes we focus over here, but for us, this is a part of a larger picture, really. And now, I have a few minutes left, so I'm going to sort of switch track a little bit and just say something else about this. internationally, when you go to conferences, especially when you talk about the big cloud vendors like AWS and Google and Microsoft and so on, and also big places like Mayo Clinic and Harvard or whatever, when they're talking about health data platforms, they're thinking about this guy over here. They think about analytical use of data. Because they think, well, the primaries, that's already taken by Epic, so nothing to do about that. So for us at Karolinska, it's very clear that yes, we will have, for quite a long time, traditional health information system to the left, and we have need of advanced analytical capabilities. And for us, openEHR really sort of glues everything together and enables these different components to work together. And then you see this box is drawn a little bit more, it's not in the middle, so even though openEHR for us is mainly used for primary use, direct support of healthcare, as I already told you, we also use it for secondary use of data, especially for quality reporting and research. And there's a few examples. And it frustrates me endlessly that people can't keep apart what the operational decision support is versus an analytical decision support. Because this is sort of after the fact, you can see what happened. But over here, you have to be over here if you want to have a decision tool to help you choose the right dose of a medication, for example. You can't do that over here based on that data. So you have to make sure, am I on the left side or am I on the right side? We need both. Okay, I couldn't help myself. What are we actually doing? I promised to be brief. This is just an example of what we're doing. The kind of use cases we're looking at Karolinska right now as we speak is very unspecific. I don't have time to go into this, but I just want to point out, of course, there's a lot of potential for generative AI in healthcare. And we're looking into all these different things right now and trying to see how we can make the best use of it. So I'm not going in too much into that. I'm just going to point out this, that a lot of our important is actually unstructured. And it will be unstructured for quite a long time because it's a lot of work to go from unstructured data to structured data. So we have to take into account, okay, what are we going to do with these unstructured nodes? We can't just ignore them. And this is just an example. Symptoms and findings of, you can read a few of these. Notes a decreased appetite and an unintentional weight loss. That's actually quite significant, as you have to know about these things. But these kind of things, especially for all you clinician colleagues, if you look into a typical health record, the symptoms and findings are often the most unstructured part of the health record, because mostly you have diagnosis is often coded. If you have done something, surgery or whatever, that's also coded. But symptoms and findings are often just in a chunk of free text. So we have to do something about that, because there's a lot of really significant data hidden there. So this is an example of what we have done. And for all of you who went to Siddharth's very nice presentation yesterday, wonder why do we go from speech into written text? You can do it so nicely with, where's Siddharth? You see over here? No, he's not here. Because you can do it in real time using openEHR. But we can't use openEHR for this because we can't actually, at least not in Sweden, send patient data out into an unknown cloud where we don't know what happens with that data. So we use local language models. So, and for those, we go to written text and then use natural language understanding and to map it into openEHR to specified, in this case, cardiology-specific openEHR template. And then a clinician can review it and say, it looks good, okay, let's document it like that. Not very sexy, but it's very useful. Another example, finding patients with undiagnosed rare disorders. Once again, the background to this is kind of interesting because my clinical specialty is I'm a clinical geneticist. I have a lot of colleagues that are totally frustrated because now they do about 60 whole genome sequencings every week, but because it's very fast, it's automatic, but the phenotyping to know the patient's problem is a lot of manual work. So they have a huge backlog where you have to go through the health record and see, okay, what were the patient's problems? We don't have the time to do it. So we're helping them. We use natural language processing to extract the phenotypic features from, for example, GP notes, some stuff like that. And we map it to something called the human phenotype ontology terms. And then, actually, they're stored in an openEHR template. And then we do something called, we vectorize the phenotypic profile. Doesn't matter what it is really, numerical representation, but it means that then we also have vectorized the phenotypic findings of all the rare disorders. So we can do a similarity search. How much alike is a patient's symptoms to all these rare disorders? So we can match them and get the most likely disorders for a particular patient. Very useful. Anyone interested in mathematics, it's not rocket science. You can play around with this. Also very useful. But this is my last slide, just to go back to the most important thing, really. If we don't have the data, we can just go home. So we can just forget about AI, we forget about all the cool stuff. So my overarching goal every time I go to work is to make sure that everyone at Karolinska University will have the right information. We can provide to the right people in the right format, through the right channels at the right times. Then we're talking. Then we're actually getting somewhere. So thanks for your attention.
We have 3 minutes for questions. Any questions?
Yeah, hi. First of all, very, very great presentation. I really like the approach of saying that this is a transitional part and it's not a big bang where we go from traditional HIS systems to what we are all working for. So do we have some kind of time frame in your head for the transition, for the process of that you think we don't have the traditional systems anymore? Because from what I understood is that it's not today, but it's a transition towards that, because I think there will be no best of suite in the future when best of breed is also some kind of integrated.
That's an extremely good question. I think my usual answers to that is that really the problem for us is not the vendors or IT in general or anything like that. I think healthcare is its own worst enemy, because as long as the clinician don't have the know-how to really with confidence enter into these discussions with the decision makers, with the politicians and with the market, to have an engaged dialogue, we will never get there. But if the clinical community actually, I hesitate to say grow a spine, perhaps, but actually make sure they have the knowledge to enter into these dialogues, then we can get things moving a lot more quickly. But I think Tomáš and I talked about this the other day, that one problem is that the whole incentive structure is wrong, because many of our decision makers, wherever we are in the world basically, unfortunately, in many cases, they don't have the incentives to do the right thing. It makes more sense for them to say, okay, let us outsource this whole mess to an external vendor, because at least then we have someone to blame. I mean, so unfortunately, it's not always that the best solution wins, unfortunately. But I think anyone who feels the pain of the situation we're in should try to sort of learn as much as possible and make sure they engage in the dialogue. And I think at Karolinska it is possible. You can do it, but it was not a quick fix. I have been at it for, I don't know, Tomáš, the first time we met was in 2015, 2016 or something like that. It's been a hard slog, but we're moving ahead and gaining speed. So the brief answer is, it's really up to us how long it will take. Yeah, I can't give you a better answer than that.
Thank you, Patrik. Let's give him another round of applause.
Yeah.
Thank you.